Welcome to Crisis Intervention, Social Work 645. I'm Jay Callahan. Um, this is the first in a series of mini lectures that I'm putting on video that would ordinarily be the kind of lecture and discussion that we would have in class if we were able to meet in person. So if you have questions or comments or thoughts about any of this stuff, I hope you'll write them down or remember them and bring them up at our synchronous session later this week. As you can see from the syllabus, the idea is to watch these 2 or 3 videos, read the written material, written literature that's in the syllabus and Sakai, and then we can have good discussions when we do meet together. This first introduction kind of mirrors the structure of the course as well, in that I'm going to be talking briefly about crisis and crisis intervention, which is going to make up the first half of the course. And then secondly, emergency and emergency intervention, which is going to make up the second half. The other issue is if you've read my book chapter, which was assigned for this first module 1, the first week, then you'll see that much of the material is similar between that book chapter and what I'm going to be talking about right here. So let's start off with a definition of a crisis. What is a crisis? Well, it's an upset in a person's psychological equilibrium or emotional stability. We all function more or less and at a level of stability, and sometimes something knocks us off that stability. Crises are typically caused by a stressful event, and that stressful event can be either normative or traumatic. A normative event is a stressful event, but it's something that's kind of part of the ordinary issues of life that come up for people. Difficulties in relationships, a loss of a relationship, a breakup, a separation, perhaps a job loss or the threat of a job loss, financial problems, legal problems, illness or family illness short of death, things like that. These are the kind of things that are part of ordinary life. These are normative stressors. The other kind of stressor is a traumatic stressor, and we'll certainly talk more about this later, but basically a traumatic stressor is one that involves death or the threat of death or serious physical injury or sexual violation. A crisis means a person is entered a time when they are unable to cope successfully with the stressful event and the situation surrounding it. So there's a temporary inability to cope. Their normal coping mechanisms don't work, and that's almost by definition. If they were able to cope with the stressful event, they wouldn't have a crisis. Since they do enter a crisis, this period of psychological disequilibrium, then that almost by definition shows that their normal coping mechanisms did not work. Now, what do I mean by coping mechanisms? Well, that's just there are numerous kind of techniques, attitudes, behavior, things that people do to cope with the demands of life, to cope with the stress of life. Some people have a drink. Some people take a walk in the woods. Some people talk it over with a close friend. There's numerous things that people do, exercise, read a book, watch TV. We could go on and name numerous things that people do to cope with the stresses of life. Many people that I see in my private practice who have fairly stressful jobs, that their way of coping with it is come home in the evening and veg out by watching TV. Many, many people do this, and it's a way to cope with ordinary daily stress. When we talk about a crisis, though, we're talking about a stressful event that, for whatever reason, overwhelms the person's ability to cope, and then they have a period of functional impairment. Functional impairment means that their functioning in life is impaired. They're not able to function at their normal level. If they have an office job, they go to work, but they can't concentrate, they can't focus, they give up and go home, or they just space out and stare out the window. Or if they work at home, they can't seem to get done anything, can't focus on what they're doing, that a person is just unable to function at their normal level. A crisis goes on from roughly 3 days to 6 weeks. Now, in the literature, the maximum of 4 to 6 weeks has been pretty well established, although I don't think that there's any empirical literature about this. It's just that the descriptive literature about crisis and crisis intervention, which goes back 60, 70 years, always focuses on 4 to 6 weeks. As a minimum, there hasn't been really anything in the literature, although I think it's clear that we have to say that there is a minimum, that a crisis, you can't have a crisis for an hour, or you can't even have a crisis for 1 day. I think that minimizes the seriousness of what a crisis is. So I have somewhat arbitrarily chosen 3 days as the minimum duration of a crisis, and I chose that because that's the minimum duration for acute stress disorder. Now, not everybody who goes into a crisis due to a traumatic stressor has acute stress disorder, but many people do. And as you know, an acute stress disorder has a minimum time frame of 3 days, goes up to 1 month. During a crisis, a person has symptoms of anxiety and depression, waxing and waning, but they're pretty upset, they're anxious, they're depressed, they're preoccupied, it's difficult to cope. And the term crisis, as we're using it here technically, I know this is different than how people talk in everyday conversation, but a crisis doesn't refer to the event, it refers to the state of the individual. Now, I know, for example, with the pandemic, people talk about the pandemic as a crisis. And, that's fine. That's how people use the word in everyday conversation. But the technical term, a crisis, refers to the individual. A stressful event happens. Some people handle it well. Many people handle it well. We'll talk about this soon. Many people handle it with resilience, but other people do not. And the people who are overwhelmed by that stressful event, who can't cope with it, then enter a state of crisis. So the crisis refers to them, to the person. And then finally, one other characteristic of a crisis is that when people are in a crisis, they're open to trying new coping methods, new different ways to deal with things than they otherwise would ordinarily be. So a person who would never, for example, choose to go see a social worker might, when they're in a state of crisis, do so. Okay, so now if that's a crisis, what's crisis intervention? Okay, well, crisis intervention is brief treatment for that individual initiated while they're in the crisis. It's a form of supportive or focused brief psychotherapy. We'll be talking about a model here in this class called the problem-solving model, which was originated at a mental health center in Los Angeles. And it's of 1 to 6 sessions during the crisis. Okay? The goal is the alleviation of the crisis. It's not meant to try to resolve any other pre-existing problems or issues. Sometimes we get into difficulty if there is a pre-existing issue, especially alcohol or drug problems. We'll talk more about that later. But the goal is to get the person back on track, back to their normal level of functioning. In some really positive cases, people end up functioning at a higher level than they did before. In some unfortunate cases, people end up functioning at a lower level than before. But most often, people end up back at the same level of functioning after the crisis comes to an end. The general guideline is that when someone is in a state of crisis, we should see them within 24 hours. So you're on intake at an agency, somebody calls up, and through your initial brief conversation, you get the general sense that they really are having difficulty coping, struggling to deal with what's going on, that through a few questions you can ascertain that they are not functioning at their normal level. Then the guideline would be to invite them to come in to meet with you or someone face to face within 24 hours. Don't let more than one night go by. Okay, now we'll talk about emergencies. First of all, when we talk about emergencies, we're talking about mental health emergencies, not medical emergencies. And that may be obvious, but I just feel the need to say that. A mental health emergency is an immediate situation that requires an immediate response, or harm might come to some person. Okay, an immediate situation. It's an immediate situation that takes place over the course of perhaps a few hours. It's not like a crisis which goes on for days or weeks. Actually, I probably should have mentioned earlier that these definitions of crisis and emergency are, I think, important because, as you probably discovered, out in the real world of mental health practice, a lot of social workers as well as other mental health professionals use these words in all kinds of undefined ways, all kinds of different ways, interchangeably, for example, and you'll hear all kinds of different ways that people refer to this. But I do think there's a lot of value in being able to be clear about what's a crisis and what's an emergency. The most frequent examples of mental health emergencies are potential suicide, potential violence, and potential victimization. In this course, in the second half, when we deal with mental health emergencies, we'll be focusing on potential suicide. There's just not enough time to do with the others. I have a couple modules about potential violence that you will be able to watch videos, but it won't be a main focus of the course. Okay, so mental health emergencies, most of them arise out of a state of crisis. That is, for example, a person might be in a crisis due to a job loss, and that crisis state, as they perhaps get more and more desperate, ends up in an emergency, and in particular, this could be a suicide attempt. Or some of you are probably familiar with the term of to go postal. And to go postal actually refers to a number of cases that happened, 20, 30 years ago, when employees of the U.S. Post Office lost their jobs for whatever reason, and went home, got a gun, and came back and shot or attempted to shoot the boss or the supervisor or whoever they felt responsible. So the explosion of violence that they had after the traumatic event, the normative but stressful event of losing a job, led to the emergency of potential violence, and that was going postal. Now, let me go back. I want to point out that in each of these examples, it's important to keep in mind that it's potential suicide, potential violence, or potential victimization. It doesn't mean that it has to have happened already. In fact, the idea about being able to identify a person who is having a mental health emergency is that we can do something, we can intervene before they actually try to kill themselves, try to harm someone else, or whatever. So the signs of a mental health emergency vary, but it's anything that you hear from a client or about a client that makes you think they might be potentially suicidal, they might be potentially violent, etc. So that might be you talking to one of your clients and who you've been seeing for a while, and they come in one particular appointment and say, I don't know, things have just been getting worse. I don't know what to do. I haven't been able to get a job. I'm afraid I might get evicted. I'm not sure what to do. And sometimes I don't even think it's really worth going on. So I would hope if you hear a client use a phrase like, sometimes I don't think there's any hope of going on or any reason to go on, that would prompt you to ask them if they're thinking about suicide. Now, we're going to talk in a lot of detail later about how to ask that. I will mention it when we talk about crisis intervention, because that is something we need to check in with people. But just for the point of our discussion right now, the idea simply being, when you hear anything that makes you think a person might be thinking about suicide or might be thinking about being violent, then we have to ask about it. An emergency isn't defined after the fact, like it turns out, well, they did try to kill themselves, so I guess it was an emergency. It's any information that makes you think there might be the threat of suicide, violence, or victimization. So, as I said, most mental health emergencies arise out of a state of crisis, and as I've just been alluding to it, the eventual outcome is irrelevant. This is what we define a situation beforehand, and the point is that's the way we know how to react, and that is to see that person right away. So, for example, a middle-aged man clutches his chest and falls to the pavement on Michigan Avenue. If you're there or someone else is there, hopefully you call 911, the paramedics come, they take the guy to the hospital, and it turns out later that it's simply a bad case of indigestion. Okay, the point being that was an emergency. The fact that later on it turned out to be something benign is irrelevant. The point of the definition of an emergency is to tell us what to do. So when a middle-aged guy falls down clutching his chest on the street, that becomes an emergency because it's the threat of a heart attack. If, on the other hand, a client says, sometimes I can't stand it, I'm so sick and tired of my neighbor, his dog poops in my lawn and he won't do anything about it. He cut down that tree limb that was my tree. I've tried to talk to him. I'm really getting really sick of it. I called the police on him and the police won't do anything. I just don't know what I do. That would ideally then prompt you to say, have you had any thoughts about getting back at him, doing something to him physically, getting some revenge, if you had any thoughts like that. Okay? So the outcome is irrelevant. It's a question at the beginning of a situation. Is there the threat of suicide, violence, or victimization? So the point of it, as I say here, is chest pain leads to a decision to get the guy who falls down on the pavement to the ER, and the threat of suicide gets us to do an immediate risk assessment. Which leads us to the emergency intervention. So the emergency intervention is a one-shot intervention that's instituted as soon as you can after you've received that information that made you think there might be a risk of suicide, violence, or victimization. If you're talking to one of your clients on the phone and they mention that, then you should invite them to come in and see you right away, or go to their local hospital ER right away. If it's a client who's right in front of you, then you shift from whatever you ordinarily would be doing, including crisis intervention, and shift to focusing on the emergency, the mental health emergency. So if in crisis intervention we say, when you get the general picture that someone's in crisis, see them within 24 hours. If you get the picture that someone might be having a mental health emergency, then see them immediately. So what do we do in this emergency intervention, this one-shot intervention? There's three parts to it. There's a general assessment. By the way, I use the word assessment and evaluation interchangeably. So this is an assessment part, which includes a general assessment, which is what you would do with anybody. Like intake information, you might say. Who is the person? What's their situation in life, occupation, family situation, demographic information, just the general picture of what's going on, and the general picture of what leads them to be either in a crisis or thinking about suicide, violence, or victimization. And then the second part of this assessment is the risk assessment. And this really is the meat of it, the core of it. The risk assessment is looking at risk factors and protective factors. So a risk factor is something that makes, in the case of suicide, a risk factor is something that makes it more likely that the person might attempt suicide in the next few hours or the next few days. And a protective factor is something that makes them less likely to attempt suicide in the next few hours or the next few days. So they're kind of the opposite of each other in some ways. There's some protective factors that are not simply the opposite, or they are, but we talk about them in a different terminology. But basically, it's a weighing. It's a weighing with risk factors on one hand, protective factors on the other hand, in the context of the person, and coming up with a rating of high, moderate, or low risk. And then part two, or step two of the emergency intervention is in-session treatment. What can we do in this one session to try to lessen that risk? And I'm talking about basic, social work counseling 101 here. Active listening, empathy, clarifying, precipitating events, helping a person understand what they're feeling and why they're feeling it, drawing connections between events and how they feel, basic counseling skills. And then the third part is the disposition or plan, like what comes next? What's our next step after this? And to circle back very briefly then, if your risk assessment by the end is that the person is high risk, then by definition, a person who's high risk needs containment or hands-on prevention, such as hospitalization. We're obviously going to talk a lot more about this. A person who the risk assessment yields a rating of moderate would then need more intensive outpatient treatment. And usually it's, since so many mental health emergencies arise in the context of a crisis, this would be continuing the crisis intervention, but with a special focus on their thoughts about suicide. And if the risk assessment yields a rating of low risk of suicide, then you simply continue outpatient treatment, whether it's crisis intervention or routine outpatient treatment, or if they're not in treatment, if this is the first session, then you try to initiate outpatient treatment with somebody. I'm not saying it has to be yourself. All right. So the core element of this is the risk assessment. All right. So that's our first video mini lecture, Introduction to Crisis Intervention and Emergency Intervention. Again, if you have questions, comments, examples, or whatever, please remember them, and we'll talk about them this Thursday in our synchronous session. All right, so I'll see you then.